with the agenda, Giselle?
Yes, thank you, Alosh. To begin the webinar, we'll start by an introduction, which we have already done. And then later on, we're going to give the vote to the speaker, who is Temilola Adeni, and she's going to talk about the barriers to access and uptake of sexually transmitted infections, testing, and services in the Black community. After that, we're going to have a question and answer session, and then we'll end with the closing remarks.
Excellent, thank you. And Giselle, the housekeeping as well.
Before we give the mic to the speaker, just some housekeeping. Please, can everyone make sure that the mics are on mute, and please switch on your camera if you can. And if you have any questions, just raise up your hand or use the chat box, and we'll be able to answer your questions. Thank you very much.
Thank you. Thank you so much, Giselle. And then I invite you, Toby, to give a quick intro to Temilola.
Yeah, good afternoon, everybody. Thank you for joining the webinar. I'm sure you're going to enjoy this section and also learn. So, very briefly, I'm going to be introducing the speaker to every one of us. Don't mind arguing. She's actually a scholar and an achiever in the field, so I'm sure we have a lot to learn. So, Temilola Adeni is a passionate public health researcher with a strong commitment to addressing health inequalities and improving access to care. She's got a background in mixed method research, project management, qualitative data analysis, and she has also made remarkable contributions to public health initiatives back home in Nigeria, West Africa, and also in the UK, including coordinating research activities as a community researcher on the Common Ambition Bristol project. She holds a master's in public health from the University of Bristol, and currently she's undertaking a pre-doctoral fellowship at the University of Bristol, I would think. So she's conducting a scoping review of barriers and facilitators to sexually transmitted infection testing among people of African and Caribbean heritage in the UK. With a passion for diversity, inclusion, and the democratization of knowledge, Temilola brings a unique perspective and is committed to fostering inclusive research environments and leveraging lived experiences to inform the development of culturally sensitive and accessible health intervention. Distinguished ladies and gentlemen, I present to you a scholar in the field, Temilola Adeni, as she delivers a topic. Thank you very much.
Thank you so much, Toby. And then, yeah, I'll stop sharing the screen, and then Temilola will enlighten us all.
Okay. Okay, thank you so much for the warm welcome. I really appreciate it. Yeah, I don't think I need to do an introduction again. Because of thank you very much for that warm welcome. Hi everyone again, and nice to be here on this platform to share what I've been working on. And for the past 5 years, my very specific area of research has been in sexual health, and so it gives me so much pleasure to be here once again to talk about the things that bring me joy, because I am someone that I'm an academic that is very interested in tackling health inequities and not just making research but making real world impact. And I feel very strongly that sexual health is something that not everyone gets to talk about, but it's like that elephant in the room that is like a problem, but no one is doing anything about it. So yeah, thank you once again. And quickly, how many minutes do I have? Just so I know.
I think you'd probably have about half an hour for the presentation, and then we'll do questions and 10 minutes of questions.
Okay, thank you. I will be sharing my screen now. Just a minute, please.
No problem.
ALIBSA. Yes. I'm sorry, I don't know why it's not coming up.
If you want, we could ask Toby to share the screen for you.
Yes, please. That would be lovely.
Perfect. Toby, would you be able to do that?
Okay, just give me a second, and I'll have it right up there.
I don't know why it's not popping up on my screen. Yeah, thank you.
So just let me know when I need to move to the
Yeah, thank you so much. It makes it more easier for me. So yeah, today I would be presenting the findings from my scoping review. Like the introducer mentioned, I am currently doing the NIHR Predoctoral Fellowship at the University of Bristol. On paper, my job title is Predoctoral Research Associate. I think it's very fancy, but is a very 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 interesting opportunity to prepare me for a career in research, particularly in qualitative research. So it's a very good fellowship. If you want to go ahead and do it, I would be more than happy to speak to anyone that is looking into that. And so because of the opportunity that the fellowship has afforded me, I am doing a scoping review, looking at the barriers to access and uptake of STI testing and services, particularly for Africans and Caribbeans in the UK. So next slide, please. Thankfully, I would no longer be talking about myself, and I will just go straight into the presentation. Why is STI and the services and testing, why are they important? For me, I would say the importance of STI testing and services can really not be overstated, because number one, sexually transmitted infections, or STIs as I would be calling it, is a significant public health concern, not just in the UK, but globally. And when STIs are left undiagnosed and untreated, it can lead to serious health complications, particularly for pregnant women, causing infertility issues, causing pelvic inflammatory disease, and for like everyone generally, it can cause an increased risk of HIV transmission. And so testing for STI is very important for early detection, prompt treatment, and just to prevent the spread of infections to other people. Why is there a disproportionate impact of STI particularly among Black community? First is because there are higher diagnosis rates than there are testing rates. And why? Because not many Black people go to access STI services. There are a number of reasons, which I would be heading into very, very shortly down the line in the presentation. But because of this disparity, because we have higher diagnosis, we have low testing rates. And if people don't know that they are carrying, or if people don't even know their diagnosis in the first place, or they've been diagnosed of, oh, you have STI, but you're not getting treatment for it, it means that person is at a risk of passing it to other people. And that's why the numbers keep increasing, but not many people are accessing testing. And it actually breaks my heart, because testing is something that is supposedly free in the UK, and everyone should be able to access it. Yet we keep finding several barriers, and what I am doing in my research is trying to break down these barriers and get many Black people, in the African and Caribbean community, to access testing. And I would be using a combi model in this presentation to sort of guide the way I am presenting the barriers. What is a combi model? First is it's a framework that establishes that behavioral change occurs when individuals have like the necessary capability, opportunity, and motivation. One thing with combi model is looking at why are people acting the way they do. So in this context, why are people not accessing STI testing? Why are there less testing rates, and why do we have high rate of diagnosis, increased STI burden in the Black community? And so the first barrier that I will be talking about is, sorry, I think you skipped a slide. We have the capability barrier. Thank you. The capability barrier slide. Thank you very much. It is, first is, this is the first model in the combi framework, which says capability. First is, we found that in the review, we found out that there is low STI, not only STI, but HIV knowledge and awareness, which is one thing that is very significant, like a very, very huge hindrance across all the multiple studies, which are not even so much in the first place. In the UK, I think I found out about 10 studies, not very recent, that have been focusing on the Black community in terms of STI or HIV. Or HIV/AIDS in itself, all the sexually transmitted infection, not very this particular research area, it's not funded, it's not as generalized as it should have been, considering the testing rate and the diagnosis rate. And so not many people have knowledge of testing procedures. There's like a lack of knowledge about STI transmission. How is it passed on to other people? Where do I go to test? What are the available services? And another capability barrier that was identified is language difficulties. So many of our people have limited English proficiency. So understanding information and communicating with healthcare providers is a bit of a challenge, and this deferred many people from accessing testing. And so moving on to the next slide, please. Thank you. The next barrier is the opportunity barrier. Don't forget, I mentioned the combi model: capability, opportunity, and motivation. So this is the second in that framework. And under opportunity barrier, I have broken down to social opportunity and physical opportunity. So this is the social opportunity barrier. The major social opportunity barrier is stigma. And stigma is a very big issue. I can literally take the whole day talking about stigma, because there are several forms of stigma. First, there is perceived stigma from communities. People, you've not gone to these testing services, but you already harbor it in your heart that they are not going to attend to me. They won't know what I want to say. They are going to judge me. This and this is going to happen. So perceived stigma is a form of stigma that was highlighted in the issue. Another stigma is experienced stigma and discrimination from healthcare provider. This is the one that people have actually experienced. So when I interview people, I've had participants mention to me, and they say, when I go to this place, the person I met spoke to me from a place of judgment. I felt like I was being judged. I felt like, because of my sexual behavior, I can't amount to anything. So it's like this experience, stigma and discrimination from healthcare providers themselves deter people. So when other people ask these people that have experienced discrimination, they'll be like, oh, don't go to that particular place. They're not very good people. They won't attend to you. And so that just deters that snowballing of information deters the rest from accessing testing services. Another stigma is discrimination based on race. this is where I call it intersectional stigma, because stigma based on race, based on ethnicity, based on sexual orientation, based on immigration status, based on gender identity. This is like there's a theory called intersectionality theory that looks at the intersection of identities, in this case, intersection of stigmas. So because I'm a Black person, I am a woman, I am an immigrant. So all of these things are just interwoven together. And when I think about all these things, they're like, no, you can't do this because of this. No, you can access testing because of this. And people have questions like, oh, because of my immigration status, I don't think it's going to be free. I don't know if I'm positive. What if they send me back home? These are the questions that some of our participants have asked in the interviews. And so it is part of the social opportunity barriers. Another barrier is lack of community support and negative social norms, because STI stigma is a big issue in the Black community. There's a lot of finger pointing, there's a lot of ush conversations around, oh, STI, oh, this person is so I've heard people talk to me and they be like, oh, HIV is a death sentence. So I don't want to associate with someone who is HIV positive, or someone who's got gonorrhea, or someone who's got chlamydia, or and all of these different STIs. And so in the topic guide, we've asked questions like, would you have someone who is HIV positive as a friend? And they be like, oh yeah, I can. I can talk to someone. I can have a friend who is HIV positive. And other people, and they also go on to say, but no, I can't have a sexual partner who is HIV positive. I can't bring someone who is HIV positive into my home. And so, yeah, just this seemingly isolation, isolation that people have felt if their diagnosis is positive. The isolation, social isolation that they have felt from like community members, people who are friends and family, is a barrier. Another is inadequate provider training and support. So this is still falling back to the healthcare providers, because in African countries, before you go on to test for HIV or one of these STIs, you are expected to provide pre-counseling, you're expected to provide post-counseling, and this is not readily available here in the UK, which is something that, okay, so what if I'm positive? What happens? There's like that huge gap in information is not there, and this is something that healthcare providers need to be trained on, so that they can deliver adequate care and support from their end. Next slide, please. So still on the opportunity barriers, like I mentioned, on that opportunity framework, I've got social opportunity and physical opportunity. First is poverty and cost issues. Like I mentioned, people are unsure if I'm struggling. I have work. I've got bills to pay. I don't have money to shell out of my pocket to go test for HIV. I don't have money to go test for STIs, and I don't know if it's going to cost me. I don't know what the cost is going to be. So this has been identified as one of the physical opportunity barriers. Another is locational and accessibility of testing services. Like inconvenient clinic hours, wait times being excessive. People have reported that they've had to wait hours and hours and hours on end. And here in the UK, we all understand that your time is really important, and also geographic inaccessibility, where the location of the testing service is very far from people's homes, and so this just deter them physically from attending these services. Next slide, please. Thank you. So moving on to the motivation barrier, which is the last on the Combi model. This just encompasses fear and anxiety about testing or receiving positive results. So people be like, what if I am positive? Am I going to die? What's going to go on? Just that fear of not knowing the outcome of your results and unanticipated negative consequences like relationship conflict. What if my partner leaves me? What if I lose my job? What if I get my housing taken away from me? This has deterred individuals from seeking testing. There's also been issues around confidentiality and just general distrust in the healthcare system. People have this very deep mistrust. Is actually a big thing. When I was speaking with one of my supervisors who is on the Beaver board of trustees at the Beaver conference, and he just mentioned to me that several people, he's had several conversations with the Black communities having just this deep mistrust of the NHS around around the system's ability to protect personal information, around them not being able to treat Black bodies, and just this mistrust alone is a deterrent to accessing testing services. Next slide, please. Thank you. So now I will be moving on to the intersecting factors. I brought this out because the review identified several intersecting factors that influence testing behaviors. And first, like I mentioned earlier, is intersectional stigma, where STI stigma intersected with racism, xenophobia, homophobia, stigma towards stigma as a result of your race, towards marginalized group, stigma as a result of your sexual orientation. And so this has profoundly shaped people's testing experience. Another intersecting factor is cultural norms and expectations. And so because of our background and upbringing, there's this prohibition around discussing things like sexual health, things like sex is like, and no, you're not supposed to talk about sex in public. Oh no, you're not supposed to talk about STI in public. And also because of our religious belief, have also impacted testing decisions. Another intersecting factor is gender differences, where with women facing additional barriers as a result of cultural expectations. So I've had the issue of sexual purity emerging as one of the where women are expected to remain sexually pure, and so you shouldn't even be thinking of STI testing, HIV testing when you are supposed to be keeping yourself pure. So that alone, you can't even want to have conversations around these issues because of the additional barrier that women face. There's also like this gender power dynamics in play where men are less likely to seek healthcare services because it's seen as being weak, or you don't need to go to an hospital, you don't need to go see a GP because you're a man, you are supposed to be a man. And so this very just the gender differences in general, I brought it out as part of the intersecting factor. The last factor is talking about high risk subgroups. So groups like youth, teenagers, men who have sex with men, also known as MSM, and substance and drug users, they also have like very unique barrier because first, someone who is who's got a drug addiction, is or first priority would be wanting to get their next fix rather than thinking whether they are at risk of HIV or they are at risk of any of the other STIs. And so just this different dynamics to them is part of the intersecting factor that influence testing behavior. Next slide, please. Thank you. So I have spent a lot of time discussing barriers, and really facilitators when discussing. So after discussing barrier, we need to talk about facilitators. We need to get our head around, we need to start having conversations on, okay, so we've identified so many barriers. These are real life issues that are not just like words on paper, that real life issues that people are facing. And so what do we need to start doing to address these barriers, which is why I've got this slide on here. And the first is community engagement and education. There's a really interesting book that have just been released by 3 authors in the UK called Our Stories by Us, just highlighting stories of people with people living with HIV in the UK and their own experiences. And one of the things they've mentioned in the book is you really can't say you want to solve a problem or you want to try and tackle an issue without doing proper community engagement and education. And so things like incorporating culturally relevant messaging, trying to focus should be geared on increasing STI knowledge and awareness. Because back in Africa, you would literally see on a very large billboard things like, oh, HIV is like death sentence, things like get tested, all these testing messages, which are not very likely to be seen here in the UK. And so these are the things where it's a bit very ush. And this is why, you know, community engagement, education, if you want to solve a problem in the community, then get the people in this community engaged and involved in tackling this issue. Another recommendation is provider training on cultural sensitivity. This is very, 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 very crucial in ensuring culturally competent care, because we've had people say, oh, the nurse didn't know how to treat me, so she just kept on. And we, like, for someone with anxiety around needles and syringes, it might just like trigger PTSD. Like, they wouldn't want to go in when they know that the provider that would be delivering that would be delivering the care is not very competent with black bodies. And so not just competency, but for cultural sensitivity to also deliver this care is important. And last is accessible and affordable testing services. So just providing free or even low-cost testing services is important, and bringing testing to like convenient locations can improve accessibility. And last is implementing stigma reduction initiative and just ensuring confidentiality are important to create a supportive environment for testing. Next slide, please. And so, yeah, one of the initiatives to try and tackle this inequality is Common Ambition Bristol Project. I am also working concurrently with my NIHR role. I am working as a community researcher on this project, the Common Ambition Bristol Project. This is a project to improve sexual health for African and Caribbeans in Bristol, UK, and it's a co-produced project comprising of community members, sexual health staff, and project coordinators. So one of the interventions that CAB have done so far is we have 2 dedicated African and Caribbean clinics in Bristol. We've organized events, outreaches at the University of West of England. We've organized events at AfriFest. We've organized an outreach at the Black Business, I can't remember the name of that event, but it was for business leaders that are Black in the UK. I think it was in London in 2022. And so we've also utilized the media. So we've done radio ads, we've done text messaging, email notifications, and Instagram, all the social media platforms to try and get this message across. We've created different culturally relevant messaging videos to encourage people from African and Caribbean communities to normalize testing, to get more people to test, to even know what their status is, and also to reduce stigma. So next slide, please. Yeah, I just want to play this video so everyone can see and have a feel of what we've been doing so far, or our initiative. It's an ongoing project. So if you would like to just fast forward it a little bit from, I think, 38 seconds or something. I don't know if you can do that.
Please let me know if you can, if you can hear it.
It's paused right now, so I don't know if I can answer the question of hearing yet. No.
All right, sorry about that. Just give me a second. Let me just get.
No problem. I thought that was really interesting to hear that, Temilola, was really eye-opening as well. While you focus, obviously your focus is in the Black community, I'd have to say that how it is in the South Asian community is quite similar. There's a lot of shame, and people don't want to talk about these in the community as well. So I think there's a lot of parallels, and whatever is being successful in African and Caribbean community can also be used in South Asian communities as well.
Yeah. Thank you very much. And I've really found several similarities on this project with other ethnic minorities facing similar issues regarding sexual health and just testing in general. I don't know, maybe while we are trying to get the audio for the video up, if this is literally the end of my presentation, so we could get the question and answer going so people can start having conversations if you want to contribute or anything.
That's a really good idea. I was just about to say that. I think the first question is from Abalanle. Thank you, Abalanle.
Thank you very much, Temilola. I would just like to ask, do you think there is anything in place for children? Because basically, I think we've been talking about Blacks generally.
Yeah.
Well, I would just like to know do you think there is anything in place for children of probably a known, sorry, not hypertensive, I wanted to say HIV positive patient, probably who has been on medication for a while and not detectable and things like that, who lives in the UK, and if they're planning to have a family, because some of them would have come in from their country, living in the UK, but they don't know the right thing or how to go about it. I still know a bit of it when I practice in Nigeria, to be that there will be things in place to give the children immediately after the delivery, and then the testing to go about how to know if they would test positive or negative, and how to follow up with the children. Please, do you know anything about that, please? Thank you.
To be honest, I don't really know the nitty-gritty details that go into preventing mother-to-child transmission, but I do know that it is very possible for an HIV positive mother to carry a baby to full term without passing on the virus to her baby. I really don't know, because I don't have a clinical background, so I really don't know the nitty-gritty details of that, but I do know it's very possible. And even generally, maybe just having sex, there is PrEP and PEP. PrEP is pre-exposure prophylaxis, that it's a very small pill that people take to sort of protect themselves from, you know, any transmission or any, maybe if they've had sex with someone that they don't know their status, it is very, very, very advisable that that person go on to use PrEP and before the whatever. I don't know if I've answered your question.
Yeah, thank you very much for your help. Thank you.
Yeah, you're welcome.
I think Toby has just said the video is ready, so I think we could watch the video now and then come back to the questions.
Okay, thank you. Thank you, Toby.
Can you hear the audio when it started? Did you hear it?
No.
Still,
Yeah, it's
can you hear it?
no. Can other people hear it? Because I don't know whether it's my own from my end.
I think from the video, the audio part of it is cancelled. Would you just remove that? Probably that would be the problem.
What? Sorry.
The audio part, if you look at the one that we show us that the volume will be up or down, high or low. It's showing cancelled. Probably you just click on that and.
Sorry. I'm trying to find. It's not. It's full.
Oh, so what she's saying is the screen that we can see Ayodele Fatola being shared, the
Okay.
audio mic is muted.
Is it still muted now?
Yes.
Yes.
This is interesting. Sorry for the confusion. I can't seem to find myself muted anyway.
Sorry, the person that mentioned the audio mic is being muted. Can you explain where you found that out?
Okay. Is there we can just make use of the subtitles then? I think it's just probably just clear enough.
Yeah, maybe.
Because I can't. I'm trying.
I think the one way around it would be I will just play the video, just the audio from my phone, and then I'll just turn the camera on. Sorry, the mic on, and then the video will just play from there. So we'll just have it from two sources.
Okay. Let me know when you're ready.
Yeah, and I'm at 39th second now.
It's 9. Okay.
Yeah, I can play now.
What's the problem? You having second thoughts now? You don't want to?
I do. I want to be with you. I want us to get tested first.
Tested? Look, okay. I don't have a got anything. I've only been with clean women.
Sexual health tested, especially HIV for you.
What? No.
What? Oh, you mean gay? You don't have to be gay. Listen, anybody can get an STI and anybody can catch HIV. It doesn't matter about your sexual orientation.
Listen, I'm good. I carry myself clean. I don't need no checkup for no STI. My thing's good. Trust me. What are we even talking about HIV anyway? It's not 1982.
Well, exactly. It's not the 80s. Things have changed. These days, there's more information and medication. There's even a pill that prevents you from getting the infection. Did you know that? We need to let go of these myths and stigmas. Man, it would still be alive if.
Oh, so your auntie died of AIDS? But what's that got to do with you? It's not cancer. You can't inherit it, can you?
Of course not. But losing somebody close to me made it real. It made me want to do everything in my power to protect myself and other people as well. So whenever I get a new partner, I test. I always have and I always will.
Yeah, well, what if you find out that you got it?
It's better to know. And one can live a long and full life now with the infection. But the trick is to catch it early.
So you're suggesting we go to the clinic? But what will people think if they find out?
I know it's awkward going into a clinic, but it's for a reason. To check in on yourself and get treatment. And the beauty of modern times is you can order a home testing kit. I've already ordered mine, so it's discreet and nobody has to know. Hmm? I mean, you still want some of this. Here?
Oh, what then? If you're sexually active, you need to be sexually responsible. If at any stage in your life you have had sexual contact with another person, in doing that, you do, whether willingly or unwillingly, you put yourself at risk of contracting STIs. That includes HIV, chlamydia, gonorrhea, all of the rest of them. So if you've done that, you need to be sexually responsible for yourself and make sure that you're testing to make sure that you are safe to continue having the safe sex that you want, but also to make sure that you're protecting other partners if you are having sex with other people. And if everybody was doing that, then we would be in a nice, safe and loving environment.
It's really, really important that people know their HIV status, whether they're negative or whether they're living with the virus. And the reason that's important is to make sure that they get treatment and that their virus is managed. If it is unmanaged, it could potentially lead to AIDS. And there is absolutely no reason in this country that people should be dying of AIDS. The NHS offers full testing and treatment to anyone.
HIV is no longer a death sentence. People live normal lives with HIV. It's important to get treatment. Recently, it's a unique case. But the statistics of HIV is rising among Black, African, and negative. What are the reasons?
Bristol has higher rates of HIV than other cities within the UK. We know that, we've seen the figures, we've seen that that's a problem. We also have higher rates of late diagnosis within African and Caribbean heritage communities. So those are things that we really needed to tackle.
Well, my ambition for Bristol is a 3-year project funded by the Health Foundation, and it's aimed at improving sexual health services for African and Caribbean communities.
What it really means is a lot of organisations coming together to achieve 4 main aims. Those aims are increasing HIV awareness, increasing HIV testing, decreasing stigma and decreasing late diagnosis. All of that is within the African and Caribbean heritage populations here in Bristol. So it's a unique project. It's running for 3 years. It's an absolutely incredible project and everybody's coming together to really make it work.
For me, that is a really exciting part of this project. It's about members of the community telling us, because they are the people who are using services, we need to hear what they think about services, and then working hand in hand with professionals, everyone working together and bringing something different and their opinions.
I think we need to end it now because
Sorry, can you say that again?
Oh, I said because I'm a bit conscious of the time. I was thinking maybe if we do have time, we can watch to the end. But like this is where the major bulk of the message is in.
Okay, excellent. Thank you so much, Simula. I think it was a really good video. I think it'd be better for ask people questions now, of course.
Yeah, that's all right. That's all right.
Yeah, anyone has any questions, maybe send it to the, write it on the chat section or just raise your hand and then we'll give you the floor.
Okay.
I don't have a question per se, but I just I want to ask you if you find it interesting that in UK schools or in most schools in the UK, there's a sex education that is provided in secondary schools, but most of what they talk about is consent, exploitation, online abuse, grooming, harassment, rape, and all those things are really important. But the fact that they might be omitting or intentionally omitting sexually transmissible diseases, is it not really increasing the stigma that is around testing and diagnosing of the of these diseases?
Yeah, thank you for that question. Honestly, there's an ongoing project right now it's still like in the early stage because they've just got funding to kind of restructure the sexual education curriculum in secondary schools, because we found out that some of these young boys and girls go on to engage in very risky sexual behavior, and just the education around STIs or HIV is missing, just that gap that you've currently identified in the curriculum. And I think it should be included, because if you don't know the consequence, it's like you're engaging in these activities, but you don't know the consequence of what you're doing. If people are aware of the consequences, then you will be in a much better position to make the right choice or the right decision to abstain totally, in my own opinion. And so yeah, there's been an ongoing project to do that. But you know, with the UK educational system, these things takes time before it gets into policy and practice. So yeah, we can just do the little we can, because for this project it has to be 18 plus. It has to be from 18 years and above because of the context.
Yeah.
Abelanle.
Yeah, thank you. I agree with you, Giselle, because all they do is provide contraceptions most of the time, even if at all, if they are going to provide anything towards they're preventing them from unwanted pregnancy, while the ones they provide would be basically pills and things like that without the barrier method of contraception. So I think it's a good one, really, if they could introduce what you've talked about, Timilola. Thank you.
Yeah, thank you very much for that contribution.
Juliana.
Okay, thank you so much, Temila, for that wonderful presentation. So I was wondering that when you mean accessing healthcare services, apart from the fact that you mentioned stigma, discrimination, and some other things, so is it basically because they cannot access the GP or the healthcare provider, which I think it's general, irrespective of the race, or does it have to do with a particular race? Or I just need a clarity on that. Thank you.
So when I meant, I think you're referring to like the capability barriers that I mentioned in terms of awareness or information on where to go get tested, because some of these people that I've interviewed are immigrants, and so they don't have access to informations like people who had been here 20, 30, 10, 15 years have. And some of them, just not knowing if you go to these spaces, you'll be charged. Say, for example, you'll be charged 30, 50 pounds. And for someone who is still trying to put body and soul together, it's a bit difficult to cough off that amount just to, in quotes, know my status. So just harboring these questions alone would be like, nah, I am going to just prioritize bills. I'm going to prioritize work and not access these spaces. And for some is basically, I don't know where to go. That's literally it. The lack of information. It's not like it's readily available where you can ask someone and say this is the nearest sexual health service close to you. So just that lack of information and awareness. For other people, it is I know where to go, but there's an excessive wait time. Just like, and I completely understand, because the NHS currently is overwhelmed, is understaffed and overburdened, and so there is very long wait list of people. But another thing is, not many people know that there are self-testing kits that you can order online that comes to your house directly. You test in your own house, and and you send the results back to the sexual health clinic. So just this lack of information alone, you know, when you know you've got a problem or you want to get something checked and you don't even know who or what, who to point to in the right direction, that is one of the capability barriers that I pointed out in the presentation. Thank you. I don't know if I answered your question.
Yeah, that is clear enough. Thank you.
You're welcome.
Thank you so much for that. I think we've got more questions actually, but we unfortunately later not have enough time. I had a few questions as well. So in that case, the first thing we want to do, thank you so much, Temilola. It was an incredibly useful and informative presentation. It was also, you know, based on the number of questions and the questions we have, but we don't have time to ask for, shows how much of an impact it was for the members. So it was really great, and thank you so much for that. And then we want to continue to make sure that this message is in the community, so to share the slides and the presentation within the ALIBSA community. And we do have, like, you know, faith-based leaders and other community leaders, and we are hoping that they would also see it, and as gatekeepers to the community, they would also have a part to play in ensuring that we can have a brighter future. So before we go, we've got a few more things. One, is it all right if everyone can turn on their camera, and that we just want to take a screenshot for our social media and LinkedIn, etc. So Toby will take a screenshot, but it'd be great, very grateful if you could all turn on your camera. Done, Toby? Excellent. The next piece is that we have already got our webinar settled up for the next month, it should be on 29th of May. Toby, can you share the screen for the final, for the next webinar, please? It's okay. In that case, I will be able to do that. Give me 1 second. Yeah, so this is our, can everyone see it? It's just coming on now. Yeah, so hopefully you can see it. So our next webinar is on the 29th of May. And again, at the same time, so the topic would be understanding the cultural and socioeconomic factors of influencing diabetes, self-management among ethnic minorities. As you know, diabetes is a lifestyle disease, and it's very much more prevalent among ethnic minority communities rather than majority communities. So this would be a very interesting topic, and I hope that you can all tune in for next month and then be part of the webinar. But for this, thank you so much for everyone for attending the webinar, and thank you so much, Temilola, for presenting. Yeah, and yes, as Giselle says, we'll promote the flyer for the next webinar on the community group as well. But from my part and all of ALIBSA team's part, thank you so much for this. Thank you so much, Giselle and Toby, for this.
Thank you. Thank you.
Thank you. Bye.
Thank you. Bye-bye.
Thank you.